Today in our pharmacology video, we are going to talk about amphotericin B, right? So amphotericin B is derived from cultures of streptomyces. This is an antifungal drug, right? So it is found to be active in most fungi and yeasts. And it is uses especially in meningitis, oral thrush, systemic candidiasis, and pulmonary aspergillosis, among others. Around 1958, before most antifungal uh, drugs were made, this was more like a gold standard in the treatment of disseminated fungal infections. Amphotericin B belongs to a class of amphoteric choline macrolide, right? And is characterized by multiple double bonds and a large lactone ring. This drug is nearly soluble in water, necessitating preparation as a colloidal suspension with the sodium deoxycholate for intravenous administration, right? So when you see it, yes, they are oral forms that are still in development, but as for now, it's only IV. There are various formulations, right? Lipid formulations, which are used for better pharmacological properties, as I will mention in this video about liposomal amphotericin B. Alright, so its absorption is poor if you take it oral, right? So the oral forms will only be effective for luminal fungal infections. IV administration is like what's being done right now. A typical IV dose of around 0.6 milligram per kg per day that will achieve a blood level of about 0.3 to 1 micrograms per ml with over 90% protein binding, right? So this drug is highly protein bound, right? So this is just an example. If you use 0.6, only this amount will be absorbed, right? Next is about the metabolism and excretion of this drug. It's primarily metabolized with some excretion occurring slowly in urine over several days. So I will talk more about this later in this video. The half-life of amphotericin B is about 15 days, allowing for prolonged therapeutic effects. That is why in the new ambition trial, you will see that it's only given on day 1. Tissue distribution. It is widely distributed in tissues that only 2 to 3% of blood concentration will reach the cerebrospinal fluid, which may require intrathecal administration for fungal meningitis. But you will see that this intrathecal administration has a lot of side effects, so it's not being done. We just use IV for that meningitis. But just keep in mind that the 2 to 3% of the blood concentration will reach the CSF. Impact of impairment. Let's say someone has chronic kidney disease and is also supposed to be in amphotericin B. This medication, you don't have to change the doses if someone is undergoing dialysis. The mechanism of action, right? So you can see this is a typical fungal cell, right? So I'll be using this diagram over and over again, courtesy of Katsang, right? So this is an expanded view. This is outside the membrane, and then here is inside, right? So what amphotericin B does is that it makes the hose. It makes the hose on the fungal cell wall. So this will affect permeability and transport function of the cell, right? So as I mentioned, it forms large spores in the membrane, which will cause ion disturbances, ion imbalance, and loss of intracellular potassium, right, from the fungal, right? So that's the mechanism. Let's expand it, right? So it selectively targets the fungi by exploiting differences in cell membrane lipids. Fungal membranes contain ergosterol, while human cells will predominantly have cholesterol, right? So we are targeting this. That's why the side effects are actually minimal if we talk about uh, amphotericin on a functional level, right? So the drug binds to ergosterol, forming pores that will alter the membrane permeability, and its structure allows it to combine with lipids on one side and water on the other side. This characteristic is known as amphipathic, right? So this amphipathic nature will facilitate formation of multiple pore complexes, and the pores will lead to leakage of ion and macromolecules, resulting in cell death. There is some binding to human cholesterol that will contribute to drugs toxicity, but as I mentioned, it's more of ergosterol. The degree of binding to human membranes accounts for adverse effects which are observed in therapy, as I will talk about. The resistance to amphotericin B can be through impaired ergosterol binding, right? So what will happen is, well, this is very rare, but some fungi may alter the structure of ergosterol so that amphotericin B may have trouble binding to ergosterol. So another thing that can happen is decreased ergosterol concentration in the fungal membrane. That can also lead to resistance because amphotericin B now has nowhere to bind. The mechanism of action highlights the importance of ergosterol in the fungal survival, and its selectivity is key to its fungal efficacy and associated toxicity. Pore formation is a critical step in the drug's fungicidal effect, right? So it actually cures. It's not fungistatic, but fungicidal, right? Resistant mechanisms underscore the need for ongoing research in antifungal therapies, and the clinicians must consider both the efficacy and the potential resistance when prescribing not only this, but whole other drugs, right? And also it's essential for monitoring for toxicity in amphotericin B treatment. So where is it indicated, right? So as I mentioned before, in meningitis, particularly cryptococcal meningitis, IV amphotericin with flucytosine. You can click the link on the top right corner to watch the video on flucytosine, and also with fluconazole. This is actually the first line, right, in that regimen, first line in management of cryptococcal meningitis. Amphotericin B enhances the antifungal effect of flucytosine. So that relationship or that combination is called a synergistic. These two, they work together. I mean, the effect, antifungal effect, will be enhanced. And remember, I told you that amphotericin B is highly protein bound, right? So it's excreted very slowly via the kidney. That's why you also need to consider the kidney function. It's renal toxic. So, as I mentioned, there are lipid-based formulation which are available now. Those ones are actually preferred for organ transplant patients. Right, let's talk more about the lipid formulation of amphotericin B. Right, so therapy with amphotericin B is limited by renal toxicity, as I mentioned. So the development of lipid formulation aims to reduce that toxicity. Liposomal preparation packages the drug in lipid carriers, and amphotericin binds more to fungal cholesterol than to human cholesterol, as I mentioned. So this preferential binding will minimize the harmful effects on the human cell, and larger effective doses can be used with reduced toxicity because most of it will be bound like in those lipid formulation, right? So there will be like this slow release. Okay, let's just continue. You see what I'm talking about. So liposomal formulations will create an amphotericin reservoir. Reduced non-specific binding enhanced safety during treatment, and some fungi actually produce lipases that release the free amphotericin at the site of infection, right? So this is what's happening. The amphotericin B is bound to the lipid, right? So when it goes near the infection site, the fungi will produce a lipase, not knowing that it's killing itself, because if you produce that lipase, it will cleave those lipids and the drug will be released on the site of infection, right? So there are three formulations that are available: Ampisome spheres, Amphotech discs, and Abelset ribbons, right? So Ampisome spheres are what's commonly used right now. Let's talk about the side effects, right? So side effects of amphotericin B can be grouped into two groups. There is fusion-related toxicity and the accumulation or accumulative effect, right? So on infusion, right? So infusion-related reactions to amphotericin B are nearly universal, and these will include fever, chills, muscle spasms, vomiting, headache, and hypotension. And these symptoms can be alleviated by slowing the infusion rate or reducing the daily dose. Pre-medication options will include antipyretics for fever, antihistamines for allergy, uh, meperidine or corticosteroids can help managing these reactions. A test dose of 1 milligrams IV is often given to assess the patient's reaction severity, right? But it's rarely done now, but it should be done to know if this person could have a reaction, and also understanding the degree of that reaction so that you weigh the risks against the benefit. Test dose helps inform the initial dosing regimens and pre-medication strategies, and monitoring the patient's response during infusion is essential for adjusting the treatment as needed. Next is the cumulative toxicity, right? So renal damage is the most significant toxicity of amphotericin B, and nearly all patients on clinically significant doses will experience renal impairment. And the severity of azotemia varies, but it often stabilizes during therapy. But in some cases, it can escalate to the point of requiring dialysis, right? There are two types of renal toxicity. One is reversible and one is irreversible. In reversible renal toxicity, there is a pre-renal failure due to decreased perfusion. So you see that you need it's called pre-hydration and post-hydration, right? If you keep the patient hydrated, you might be reducing this risk, right? So we'll talk more about that when we talk about the approach to treatment of the patient with meningococcal meningitis, right? So you can click the link on the top right corner and watch that video. It's very important. Another type is called irreversible, right? So this irreversible tubular injury from prolonged use of the drug, especially if you are using more than 4 grams, right? More than 4 grams per day, and using that for a long time, it could actually lead to irreversible tubular injury, right? Common manifestations will include renal tubular acidosis and potassium or magnesium wasted. So it will lead to hypokalemia, hypomagnesemia. And you also see that in the video that I mentioned, how we manage these side effects, or better, how we prevent them. Sodium loading with normal saline infusion can help mitigate the pre-renal effects. Right, guys, you need to watch that video on the management of meningococcal meningitis. It is important guidelines that I think will be helpful for you. Continuing with the cumulative toxicity, abnormal liver function tests may occur alongside with renal toxicity, and varying degrees of anemia can result from decreased erythropoietin production, right? Because erythropoietin is produced by the kidney, right? So if the kidney is affected, that could alter the production of erythropoietin, and if there is decreased erythropoietin, there is decreased erythropoiesis, and there is decreased level of red blood cells known as anemia. Intrathecal amphotericin B may lead to seizures and chemical arachnoiditis, that's inflammation of the arachnoid matter. So that's why I said intrathecal is not encouraged. So I think where we are going, we are no longer doing this. But I don't know, some centers might be doing it, but I don't think it's safe. Serious neurological complications can also arise from this, and regular monitoring of renal function is essential during therapy, and supportive measurements are crucial for effective management of the toxicities. Right, so this mnemonic from Courtesy of Memory Farm study helps you to remember the side effects of amphotericin B, amphotericin for anemia, muscle spasms, phlebitis, headaches, hypotension, ototoxicity, thrombocytopenia, emesis, neurotoxicity. And you may also say that not all of these side effects, I mentioned them in the previous slides, but it's just a way to remember some of the side effects. Thank you so much. If you enjoyed this video, please make sure you subscribe, share with your friends, and most importantly, leave your comment in the comments section so that you'll know what you think. Thank you so much.